Hi everyone, welcome back to A Spoonful of Oral Medicine. I'm Amanda Punyuan and I'm very happy today to have Dr. Andres Pinto here with me to discuss oral ulceration. So Dr. Andres Pinto is an oral medicine specialist in Ohio, and we first met when he came to Perth to give a talk actually at the, when was it, in 2016 for the Oral Medicine Academy of Australasia.
Yes.
Hmm.
Yes, I
And
think it
then
was a little bit earlier than that, I think.
I was a bit earlier than that. Maybe it was 2015. And then we met again in Gothenburg for the European Association of Oral Medicine conference.
Certainly.
Yes. So how are you going over there in Ohio at the moment?
So we're doing okay as far as one can expect within this pandemic situation. But we are opening slowly as far as practice and healthcare. And luckily, the state of Ohio was one of the first states that actually closed. We were closed since March 10th.
Yes, I saw that. Yeah.
And it worked pretty nicely, and we've had not few cases, but few deaths. I think it's less than 600 deaths as far as last counted. And things are slowly trying to go into normal.
Are you working from home at the moment, or are you back?
We are mostly doing clinics only 40%
Yes.
of the time. And as far as our teaching commitments, they're all from home. Yes. And our meetings are all from home as well.
Yes. So everyone's getting very good at using Zoom. Same for me as well.
Yes, I actually have learned a couple of new platforms. One is from Blackboard or something like that. It's Connect or something like that. I'm lecturing tomorrow, the 23rd, a sleep conference in Europe. So it's using their platform, and it's quite interesting.
Nice. All right, so I'll get started. Let me share the screen with the PowerPoint presentation. So for people watching the video who may not be aware of how this works, I get a guest on, and I look on Google for the most commonly asked questions. The guest, who is in this case is Dr. Pinto, he doesn't have any idea what the questions are, and then we'll go through and have a little bit of conversation.
Fantastic.
Thank you. So today we are talking about oral ulcers. So Dr. Andres Pinto is the president-elect of the American Academy of Oral Medicine. He is founding chair and a professor of oral and maxillofacial medicine in the Department of Oral and Maxillofacial Medicine and Diagnostic Sciences at Case Western University in Ohio. He is a diplomat of the American Board of Oral Medicine and the European Association of Oral Medicine, and holds an FDS from the Royal College of Surgeons, Edinburgh. So first question, are we ready?
I'm ready. Thank you.
Not a problem. So what causes oral ulcers in the mouth? This is a very broad question.
Yeah, well, there are many causes for ulcers, and they range from trauma, hitting the mouth with something, eating the wrong thing, or scratching some type of tissue, to infectious causes, to non-infectious, like autoimmune type of ulcerations, to highly inflammatory recurrent ulcerations. We like to think about ulcers in the mouth as mirrors to bodily functions. So we see maybe increased levels of inflammation in patients with treatment actively for cancer, for example. We look out for opportunistic infections that can cause ulcers. And when I say opportunistic, they are basically microorganisms, bacteria, candida yeast, or viruses that live in our mouths normally, and they're kept at bay by our immune system, our cellular immune system. But when one becomes immune suppressed, like with cancer treatment, uncontrolled diabetes, and so forth, they can basically overgrow and cause ulcers.
So I suppose this is something that we've alluded to already. So what can oral ulcers be a sign of?
Yeah, the first thing we look for, of course, is the most simple explanations, right? The most simple explanation for an oral ulcer is trauma, and that's commonly seen in pediatrics and in small children. It's seen also in folks who are extremely anxious, or they have habits, a lot of us have habits either of biting our nails or biting our cheeks when we are highly intensely stressed. So that's the first thing we want to make sure that's not happening, or anxiety. Some children, older children, or pre-adolescents can have somatization of their anxiety by doing parafunctional. Or when I say parafunctional, basically creating a habit that creates some type of injury to their mouth and to their gum. And that's the first thing we want to make sure we're comfortable that it's not happening. And the key to this is that it's not constant, except in very few cases. It's not a constant ulcer, and it comes and goes depending on what triggers the habit. And then we go up the ladder, if you will, of diagnosis. From there, from the trauma, we go into deficiencies of basic stuff like vitamins, anemias. We go through autoimmune disease, we go through diabetes. Of course, we look at gum disease that could be bacterial, highly complicated, acute bacterial infection in the gum. And then we keep on going over a list. And I think part of our specialty, Amanda, is we spent several years of our life learning how to tease out these diagnostic lines, if you will, in terms of the ladder of diagnosis. And that's what makes us unique.
Now, are there any systemic conditions that are related to oral ulcers, and could you discuss a couple of them? So so certainly, the one that comes really obviously to my mind is vitamin deficiency or anemia, and that's a common one where you can have recurrent canker sores, for example. Canker sores are very common in the population. I would say probably a third of the population has canker sores in their lifetime. And that's something that we always want to be in the first lines of our testing for vitamin B, different vitamin B deficiencies, or even vitamin D deficiencies that are now linked to many things, among those some oral ulcers. And of course, iron deficiency anemia, the most common one. And we can also think about ulcers related to treatment for cancer, as I alluded to before. If you have somebody who's having active cancer treatment with chemotherapy, they can become very immune suppressed, and a certain level of decrease of white blood cell counts, which are the cell counts that defend you against infections. You can have ulcers just because of that, in respect to the bacterial ulcers that I mentioned before in this talk. Can people get ulcers related to gastrointestinal problems?
Absolutely. Actually, it's interesting you mentioned that. Yesterday, I gave a lecture to another university in the south of the United States, online, of course, and they were using WebEx, which is another platform that I hadn't used before. So part of the lecture was about pediatric oral medicine, and we spoke about a case that I showed them of swelling, acute swelling and edema of the lip, of the upper lip, in a young lady who did not have any other symptoms. And what we learn in dental school as dentists is a very specific pattern of ulcers or sores in the mouth that occur with gastrointestinal disease. Most of the time it is inflammatory gastrointestinal disease, such as Crohn's disease, ulcerative colitis, but also other types of food intolerance. However, we don't usually see a lot of labial or lip swelling or edema from gastrointestinal disease, especially in the absence of gastrointestinal symptoms, which is a second thing that not only us, but pediatricians and other people ask these kids and their parents if they had cramping, if they have diarrhea, bloody stools and whatnot. So absolutely, that is a common manifestation, I should say, of gastrointestinal disease. Most of the time is immune related or inflammatory related gastrointestinal disease, or allergic as well.
Now, do you see a lot of cases of Behçet's where you are?
I've seen not too many. I've seen perhaps a handful in my career. They most of the time have been diagnosed before they come to us, and they come to us more so for the management part
Yes.
of the mouth complications.
Mm.
And of course, they have the typical presentation that we know about. But the so these are the cases where you have canker sores that are very frequent. They're huge. They're big. They impact quality of life. And depending on the lifespan where you have them, and if this is a young individual, it will impact nutrition, which is a concern for their care providers. But certainly will impact somebody like you and I, who we do part of our living speaking to patients and speaking to registrars and speaking to our faculty. If you have a big canker sore in the lip or in the cheek, it can become painful, very painful to talk.
Mm. So I suppose I probably should have put this one at the front. So, so what is an ulcer?
Well, an ulcer is when the intact surface that covers your skin, when I'm talking, well, both on the skin, outer skin and the skin in the mouth, we call mucosa, which is a little bit thinner. It's when that outer surface becomes interrupted for whatever reason. So if you fall, you will have probably what we call an erosion. This is a fancy term for a more superficial ulcer or whatever. And the ulcer is when you get exposure of the underlying second layer of the skin, actually the layer where you can get infections. So we humans and a lot of mammals have a very thick layer of outer skin. Some are thicker than others. Some have a lot of hair than others. Have other protective mechanisms for both temperature changes and friction, like dogs, for example. They can, they basically are made to withstand a lot of injury and stuff like that. For us humans, we have some protection. We have a thick skin. Nevertheless, it's not very difficult to interrupt it, either purposely or accidentally. And what you see when you expose the underlying layer is the layer of more so red, when you have the blood vessels that start bleeding and stuff like that. That's where the skin actually loses its function. So the function of the skin is to protect us from the myriad of bacteria and things flying around us all the time that they don't get into our bodies. Once we interrupt that layer, then we'll have a higher risk for infection. So whenever there is an ulcer, it is a heightened risk for infection of the area, and hopefully won't be a higher risk for infection of the whole body.
Thank you. So how long does it take for a mouth ulcer to heal?
We are blessed in dental medicine because we, and this is something you hear also our maxillofacial colleagues talk a lot about. We can pretty much do a lot of things in the mouth and get away with it. And when I say get away with it, I don't mean it in a bad way. I mean it that the mucosa in the mouth is very, very giving, and it heals quite nicely. I'm talking about minor injury, of course. If there is some kind of car accident or major, gunshot wound, that's a whole different story. But overall, most of the time, you have an injury that will heal without the need for stitches. An injury that will heal what we call a secondary intention. That means it will heal on its own. You'll get a layer of material that is trying to protect the area from our own immune system. And eventually it will come intact tissue after all. Very rarely you get severe scarring in the mouth, which does happen on the skin. For those of us who had scarring or some type of injury in the skin, we probably, if it's more than 2 or 3 millimeters wide, we probably need to have stitches, and it will come down as a nice little scar after that. So it takes, to answer your question, it takes about, I know I was going around the question a little bit. It takes about perhaps a week to 2 weeks to heal, depending again on the environment where the ulcer is. Where is the ulcer? It's not in a frictional area. When I say frictional, it's basically not close to the teeth. And when we talk to students about oral sores and stuff like that, we usually try to say, well, the teeth are not your friends in this instance. I know we as dentists, we want to say teeth, but they're not your friends when they're close to an area where they can rub very much on the tissue and cause the ulcer to not heal very quickly.
So what should a dentist do if they have a patient with an ulcer that is not healing after 2 weeks?
I think that most prudent thing to do is to refer the patient for further evaluation. If the dentist is pretty sure he or she has removed any source of injury or trauma or friction that would cause any kind of slow healing on the tissue, then it's a good thing to refer the patient either to to a specialist, basically. And that's, even if I'm sure most of our colleagues will make sure that patient keeps the area clean by whatever reason, prescription rinses or whatever. But if that's being kept and the patient is being compliant and there's no healing after a few weeks, we recommend an urgent biopsy. Actually, we just had a case here where one of my colleagues, we're doing a lot of telemedicine until this week that we could go in person. So she had this patient who had this single lasting ulcer with very thick raised borders, which in other words, not good. When you see these borders that are thicker, you don't like that. And it's been there in a patient who had a kidney transplant, and she's being immune suppressed, rightfully so, because you don't want the kidney to fail. But on the other hand, we were scratching our heads, and this is one of my colleagues in oral medicine here who saw her, and she and I are going back and forth with pictures that have been sent from the family. And at this point, it's now month 2.5, where because we were closed, it was almost impossible to get any type of sampling. But now it's an emergency, right? It's really, we have this patient who has all the unfortunately right combination of factors that will make them highly susceptible for either a bad thing happening on that ulcer, being cancer type of things, or being a really bad viral infection or something that we need to intervene very quickly.
I've actually had a case like that where it was a young boy who had a kidney transplant as well, and he had a really big, deep ulcer involving his buccal, the inside of his cheek, the buccal mucosa, and it was a real process to figure out if it was fungal, if it was viral, if it was medication related, if it was malignancy. And these cases can be very tricky for sure.
They're challenging, and you feel for the patient because they're in pain. And this is particularly, I guess that both, you had a child, this was an older lady, so she was in pain and couldn't talk. And as you say, in the beginning we were trying to see, well, maybe it's her immune suppressant medication. Let's convince the service, the oncology service, to take her off that. Well, good luck with that, right? Because they see the mouth sore as not downplaying its importance, but of course they see the kidney survival as the primary focus of their work. So they decreased the dose after a couple of arm twisting sessions we had with them, but it didn't do anything. So she's back on it, and she's going to a biopsy at this point.
Now, can you get mouth ulcers from stress?
Yes. I wouldn't say directly stress causing it, but it may heighten the ability of the immune system. We know there's a clear relationship between stress and immune function. Not necessarily that you'll get an acute huge infection when you get stress, but if you are stressed, your normal bodily immune function is altered. And there's several mechanisms that are being explored for this. But we know that, for example, stress will affect directly the way your body responds inflammation-wise. So stress will heighten your response to inflammation. And in terms of mouth ulcers, it may make them worse. You probably have heard about, we all have heard about people who say they get these ulcers when they're in exams, when they're in very stressful episodes. When they're having some life-changing event, and that translates into getting either more acute onset of the ulcers or more ulcers at one time.
Hmm. With these type of ulcers that you're referring to, you mean the canker sores?
Yeah,
Yeah.
that's the most common
Yes. Yeah.
example.
Yes. So
Mhm.
canker sores, for people that are listening, is also known as recurrent abscess stomatitis. And the reason why I was smiling in that is that I get canker sores myself. And during the COVID period, I was getting them under the floor of my mouth. And I think it was because I was stressed. So
Yeah, no, I can tell you just from my personal experience, I don't get sores in the mouth, but I do have a GERD,
yeah.
reflux,
Yes. Yeah.
and I have, I guess I'm disclosing this in public, right? But I have a hiatal hernia.
Yeah.
So my way of somatizing stress, and this week has been for multiple reasons very stressful, is I start to secrete in enormous amounts of hydrochloric acid for some reason. That just when I say my gastroenterologist, he basically said that's a fact, and I did have testing with a probe and everything, and yes, my pH goes
Yeah.
way down when I get stressed more.
Yeah.
So I double up on the dose of the PPI for that, but that's not a good thing to do. But anyway, it's the same thing. I react my stress situation, instead of getting sores or getting anxious or whatever, I translate everything to my GI system.
Bad reflux, yeah. One of the things that I get told fairly often from my patients with oral lichen planus is that during a period of stress, they get a pretty bad flare up as well. Have you heard similar from your patients too?
All the time. That's a question that this question you ask is probably one of the top 5 questions, I would say. I don't know if you chose them on purpose on order of frequency when you looked at them, but it's all the time. They'll ask you, if this is autoimmune, why? Well, first of all, there's a little confusion between autoimmune and inflammatory, but that's more of a academic, talk. But if this is something that is my body attacking myself, why do I get worse when I get stressed? And yes, you basically will get flare-ups of the inflammation. You get flare-ups of the inflammatory events that are causing the lichen planus response.
Can mouth ulcers be cancer? I suppose we've already answered that with some of the cases that we've discussed.
Yes, unfortunately, yeah, of course. Not all of them, and luckily I would say if I had to give a number, 95, 96% of them are not, which is a good number to have. Nevertheless, those 4% for somebody who has them, it's 100%, right? That's always what we try to teach our students. You always have to be hyper vigilant.
Yeah.
And key factors there is duration, onset, treatment, if anything has been treated, trauma, of course, risk factors for mouth cancers or pharyngeal cancer, oral cancer, which are pretty popular now, but it's a whole conversation about smoking, alcohol, and human papillomavirus as well. But yes, they can be cancer.
So if we have any members of the public or any patients listening, what are some of the signs that their ulcer could be cancer? So from a layperson's view, so
Yes.
we've already mentioned duration, so longer than 2 weeks is something to worry about. Are there any other signs?
Yeah, I would say acute pain. Certainly all oral sores are painful. Nevertheless, if you have a sore that have a centimeter and you're having this excruciating pain, there may be something underlying it that is really not right. Sometimes we like to talk about things like caries, like being the top of a funnel, of an inverted funnel. Well, this can happen in cancer as well. You may see the tip of what is an iceberg in terms of the cancerous process, and what is really raising your alarm in your body is the pain that you're feeling. So that's something that I usually really pay attention to the patients, even if my clinical exam is marginal and I don't see really an ulcer or anything like that. But if the pain is out of the normal, then I'll pay very special attention to the workup I do with the patients, including, of course, repeat biopsies. I don't, of course, I respect a lot of my colleagues in oral surgery and in oral medicine as well. And I do have folks who've seen several practitioners over the years, and they come back with their biopsies, and biopsies as recent as a year ago that come up not conclusive. And as you and I know, biopsies are very technique sensitive, they're even time sensitive, they're location sensitive. So I would probably follow up with another biopsy at that point, even if I don't see an obvious cause for the pain that is proximal, very close to the area of pain. And the third one would be size. Certainly, if you have a lesion that is, or sore that is more than a centimeter, and you combine that with the time, then yes, I would become a little bit aware of that, and it would be a cause to raise that to my dentist.
So what happens in Australia is that some patients don't know where to go. So they might go to their dentist, they might go to their doctor. So if someone's watching this and they have an ulcer that's causing them pain, it's big and it hasn't gone away for a while, where should they go? I know it's a little bit different because you're in the US and I'm in Australia, but in general, where do they show up?
Yeah, it's not that different.
Okay, yeah.
It's not that different. What you said is exactly what a lot of people do here. So the first thing they do for an ulcer in the mouth, I would say more than half will go to their doctor. And then they will be treated, or they'll be counseled into what the doctor thinks they have. And then the other half will approach their dentist.
Yeah.
Usually when they approach the dentist, it's secondary to a doctor's referral, to the primary care doctor referral.
Yeah.
I would argue that I mean, I have family of doctors, so I can speak from experience. I would argue that oral sores probably should go to a dentist first. And if you are a patient of a practice, you've been in a practice for a long time, your dentist knows you quite well, it's very easy to get into him or her. I'm not sure how it is in Australia, but here, to get to your doctor, it's a whole different story, unless you have a very close relationship with him or her, and you can kind of jump to hoops to get to them within a week. I would say with dentists, it's easier to have access. If not to the actual dentist, you can have access to the nurse assistant or the hygienist, like in this country, hygienist or whatever, and they have pretty good training in mucosal assessment. They're pretty decent, so they will be able to say, you know what, that doesn't look right. And we, as you know, we're in the area of telemedicine, so you can take a snap of a picture, or even the patient can take a picture and send it to the dentist before, and make sure somebody's there if the actual provider cannot be there physically.
Yep, great. Thank you. Yeah, so yeah, you're right. It's not too different then. Yeah, but
so, part of that is because it's part of our training as dentists, right? So we self I don't want to turn political, and I will try not to, but we self-segregate from our colleagues in medicine because of our nature of our practice. And that's great. I mean, our career has prospered a lot, and we do great things in the mouth and cosmetics and whatnot. But it also appears to our peers, that in medicine, that we are only doing that. And that our expertise in the other stuff of the mouth, the other mucosal part of the mouth, and the systemic mouth connection is not as strong. So that's part of the reason why we may have patients go to their doc first, because that when patient thinks of a dentist is dental causes for complaints. And when a physician talks about dentist or thinks about dentist, they think about that and perhaps periodontal disease, and that's pretty much it.
Yeah, no, I agree. Yeah, it's pretty similar here. I mean, I think as same as you, I've got a lot of close medical friends, and I think our medical colleagues do a good job. But I think sometimes they would be the first to admit that if it's an oral ulcer, they would send the patient to someone who's dentally trained, either oral medicine directly or to the dentist too. So
yeah, for sure, and they welcome that, actually.
Yeah, true.
Sometimes they're like, yeah, that's great. I have you. I'm so glad you're here. Can you see this person? And they welcome.
Yes. Yeah. All right. Now, how do you treat mouth ulcers?
the most important thing is to know why it's happening. I always tell my registrars and my students, dental students, don't be afraid to ask why. Even if you ask somebody who's your professor and board certified or whatever, always ask why, because sometimes we don't know the answers. I've been doing this for a little bit more than 2 decades, and I still sometimes get that question that I tell you, you know what, I'll get back to you. And then I go out and try to find the answer, and it's difficult. And sometimes there's no answer.
Yeah.
So, but in terms of the mouth ulcers, the important thing is to kind of find out what's causing the ulcer. That is key. And if as a patient you're aware, or you can work with your dentist or your specialist to find out why this ulcer is happening, the rest is very easy, because once we know if there is a real cause underlying that, we just address the cause.
Yes. Yeah.
I would say probably in mouth ulcers, 80% of them have some cause, some really easily dealt with cause that even general dentists can deal with. The other 20% is the things that you and I deal with, where things may not be as white and black, and we have different shades and different causes, but most of the time the others are treatable. And even those, sometimes you do an educated leap of faith, and you treat it with an anti-inflammatory, and goes away. But the patient's gonna tell you, so what really caused it? You're like, I don't know. It must be inflammatory because it responded to what I gave you. But I can't really tell you if this is X, Y, or Z diagnosis, because it looks like X, it walks like Y, and it talks like Z. But it's one of those three.
Now, if we have ruled out all of the underlying, all of the potential underlying causes, and we do think that it's recurrent epistomatitis or canker sores, what is your preferred management for those?
So here we have to focus on what is important to the patient.
Yes.
Is the pain the most important thing? The pain is easily dealt with. You could sit in a chair, get a cautery, get some even silver cautery, cauterizing solution, and ablate the nerve endings. Yep. Pain is gone. Patient can function normally. Yes, they'll have a little black spot inside the mouth. So be it. If they can still eat and they can still talk, which is that the most important thing for the patient. If it's a combination of the sore that they feel like the little hole there bothering them and the pain, then I prefer to use topical anti-inflammatory medications, either that, corticosteroids, or other types of anti-inflammatory medications. So that, and of course, most importantly, keep it clean. If it's an ulcer that is not a canker sore, that is more deeper, you want to keep it clean. A deep ulcer in a healthy patient will heal very nicely. If it's not, really pathologic or really, really like a fungal or really bad. But overall, I think in our field, we are still treating very similarly to dermatologists that treat sores on the skin with low potency corticosteroids. I'm thinking about eczema, thinking about low-level psoriasis. Of course, that goes as high as you want, even to biologic therapy, if it is a really bad case.
Yeah. Okay. So this is a question that I get asked from dentists. So do I need to refer a patient for RAS, which is the canker sores?
Canker sores. If it's something that really affects the patient, I think most of this is patient-driven. I can tell you how many people they ask me just from having lunch together or whatever, and they're like, "Oh, that's very interesting," whatever. But they never actually see you as a patient, and they kind of have them every 2 or 3 months, and they just kind of deal with them for a week or so. Other people who they may have them in 2 or 3 months, but they tell their dentist, this is really bothering me. What can I do for this? And as I said before, the dentist is comfortable with doing just chemical cauterization for pain control, and that's enough for the patient, then fine. But if it's something that happens continuously, and I say continuous is really, really every week, every 2 weeks, that big source, that is something that probably should be referred out to specialists.
With patients with potential RAS, would they need to have any sort of investigations to see if there's a systemic contributor?
If they are very frequent and more than one or two areas of RAS, yes, I would certainly advise to have a basic evaluation, serology, hematology with a complete blood count would be a good start. And if a patient came to me with that, I would love it, because you saved at least a visit or two. And that will screen for the basic stuff that we look at in terms of anemia. Certainly, it's not the only screener for anemia, but it will be a nice start. But yes, they will certainly need some type of workup.
And I suppose we've already asked this, but if the dentist sees a patient with a mouth ulcer and they've decided to on-refer it to investigate or to see what the cause is, what is something that the dentist can give the patient to use in the meantime? So nothing with curative intent, but just to keep the patient comfortable until they can be seen.
Sure. So we have two things here that a lot of my general practice colleagues do. One is certainly isolate the area. So if it is a lip inside the lip or a cheek, they isolate the cheek or the lip from the teeth, and so they'll make some type of, maybe an Essex retainer type of material, some type of acrylic, very very thin, of course, acrylic material to keep the teeth away from the sore. And the other thing is, I'm not sure if you have this in Australia, we have this over-the-counter dental paste, and it's almost like a combination of a topical anesthetic. It has a very low, I think it's triamcinolone, very low potency corticosteroid.
Yep.
And it has also grainy, sandy consistency.
Yep.
So it sticks to the area wherever you put it in the mucosa.
Yeah.
That is something that they are pretty comfortable in having the patient get that. And having the patient apply that. Now, that may not be enough, but at least it will cover the area, and in many cases, it will decrease the discomfort a lot.
Yes, yeah. I don't think we've got something with that sort of texture. We've got low-dose corticosteroid ointments. We've got topical anesthetics in ointment form and mouthwash, but I haven't seen any with a really texture like you described. But I might have a look at my local pharmacy and see if there's anything else.
Yeah, I'm sure it can be compounded as well, but that is something that a lot of folks, they know it's not a very strong steroid, so they're concerned about using strong, Dexa or whatever, because of their training. They're not comfortable going that extra step, which is fine. They'll use this, and that actually it's okay. It's decent that the patient will use it until they see us.
Yeah,
it helps. Yeah. Yeah.
Great. Thank you.
Sure.
All right. So that's the end of our questions. So thank you so much for taking the time to come on this video with me today. For everybody that's watching, the Instagram handle that I have there at the top of the PowerPoint at Andres Oromet OFP, that's Dr. Pinto's Instagram. So you can check it out and see what he's been up to. I think, do you have a dog?
I do.
Yeah, I think I saw your dog.
Actually, you haven't seen my right hand.
Oh, no, what happened?
He decided to, I was picking him up. We have him at the daycare, right? So we picked him out of the daycare, and he decided to run out the door to greet somebody. Yeah. Another dog, of course. Yeah. And my hand was on the leash still, and the door was closing.
Ooh. Is it fractured or?
It's not fractured, luckily. I actually went to the emergency. It happened on Monday. I went to the emergency room. It was the first time in my life I've gone. I haven't gone to many times to the emergency room. But first time I've gone, there's nobody there. Nobody there. I got treated, x-rayed. It's not a cast. It's like the whole thing. All that within 20 minutes. And I was out of there. It's crazy. But anyway, no fracture, 4 stitches. Luckily, no tendon involved. But
Yes. All right. So if anybody sees the photo of your dog on your Instagram, they'll know what your dog has done.
Yes, they'll know him. But he's a nice dog. He's too young. He's still kind of rowdy.
Yeah, I've got a puppy too. So yeah. All right. Well, thank you so much again for coming.
It's a pleasure.
Really, really appreciate it.
Thank you. Have a great evening back in Australia.
Thank you. I hope to see you soon. Maybe at AOM next year, hopefully.
Yeah. Yeah,
All right.
soon.
Thank
Take
you.
care.
All right.
Bye-bye.
Bye.